Dear committee, dear colleagues, I would like to welcome everyone, and I would like to introduce you to my PhD thesis called Novel Therapeutic Options in the Treatment of Acute Pancreatitis. I work as a clinical pharmacist in the everyday practice for almost 8 years now. However, there are a lack of fellow pharmacists near the bedside, and my vision is to have a dedicated pharmacist in every ward to help to support the patients. And my mission is, with my everyday practice and with this PhD topics, to help to achieve this vision. Our team investigated several topics in the treatment possibilities in acute pancreatitis. First, possible therapeutic option for this. Second, widely available drug safety. Third, preventative medications. And on the side note, I would like to assess the current clinical pharmacy status across Europe. First of all, the first topic was a combination of ulinastatin and somatostatin to reduce complication rates in acute pancreatitis. Because acute pancreatitis have a fairly low incidence rates, however, it can achieve a really high mortality in severe cases. But there is no efficient pharmacon to this date. Only supportive measures are warranted in the field, for example, fluid resuscitation and lack of or specialized nutrition support. And ulinastatin, protease inhibitor, it's available in the Far Eastern countries, and it is indicated in the use of acute pancreatitis. However, in the western part of the world, it is not available, and it's an emerging medication with few but randomized controlled trials, and we would like to assess this and to investigate the clinical outcomes with this combination therapy compared to the standard somatostatin analog therapy in the treatment of acute pancreatitis. And our question was, does this combination therapy superior compared to the somatostatin analog? Our results showed that the ulinastatin combination with somatostatin analog decreased the complication rates in several departments, for example, multiple organ dysfunction syndrome, acute kidney injury, and acute respiratory distress syndrome. However, it was not statistically significant in the mortality department. It was not statistically significant, however, it almost reached it, and moreover, we can reduce the length of hospital stay about 7 days. Our conclusion was that ulinastatin in combination with somatostatin is a viable alternative pharmacotherapy of acute pancreatitis. This was the first investigation to assess ulinastatin therapy. However, there were several limitations of this, a small number of trials located only in China and high heterogeneity. We have submitted and accepted paper about this. The second project was regarding PPIs in the treatment of acute pancreatitis. It is one of the most overused medicines across all the healthcare settings. It is also true for patients with acute pancreatitis. On admittance, 20%, and during the hospitalization, 70% of the patients get prescribed PPIs, and there are lack of evidence to support this. Theoretically, PPIs can reduce not just the gastric secretion, but also the secretion of amylase pancreatic juice in 2 experimental settings. Therefore, maybe the usual PPI therapy of a patient can coincide with the off-label use to help to support the patient. However, as I mentioned, there is no evidence, and we would like to investigate, is there any effect of the PPIs in acute pancreatitis? And we compared the complication rates to the placebo. Our results showed that PPIs could reduce complication of pancreatic pseudocysts in a statistically significant way, but there was no difference in intestinal bleeding, acute respiratory syndrome, and mortality. And also the length of hospital stay was also not different compared to the standard therapy. Our conclusion was that to treat acute pancreatitis with PPIs is an off-label therapy, and however it is considered safe, there are risks of adverse reactions in the future of these medications. This was the first meta-analysis that investigated PPIs in acute pancreatitis, and also we had the same limitations that before, a small number of trials only located in China and high heterogeneity. We also have an accepted paper of this investigation. The third one is a preventative medication, nafamostat. ERCP is a minimally invasive procedure. It's endoscopic retrograde cholangiopancreatography. And the most complication rates of this procedure is post-ERCP pancreatitis in almost 10% of the time. To this day, only indomethacin combined with non-steroid aids and aggressive hydration have protective effects against post-ERCP pancreatitis, and we would like to also investigate this nafamostat protease inhibitor in the prevention of PAP, and we would like to compare it to the conventional therapy. Our results showed that it has an overall PAP prevention rate both in the 20 milligram and the 50 milligram groups. However, it only could decrease the mild PAP by a statistically significant way. In the moderate and severe cases, it did not have any difference compared to the placebo. We submitted last week this manuscript, and we are waiting for the revision at the journal. And the fourth project would like to investigate the impact of clinical pharmacist work across Eastern and Central Europe. Because clinical pharmacy services are not common, we haven't got any standardized way how to do it. There are very good island-like workshops amongst Hungary and other European countries, and there is no official benchmarking system for clinical pharmacists. It's a multi-step approach to address this field. First, we would like to have an international survey to determine the clinical pharmacist position in hospitals and to discover the most common practices. And in the future, we would like to have develop systematic reviews across each services that can the clinical pharmacist have. And we would like to have a registry established to evaluate the applied measures that we recommend for the clinical pharmacist. So first, we designed an online questionnaire. It has 3 domains: a descriptive information, second, about clinical pharmacist relationship with different healthcare workers, and third, the mentioned clinical pharmacy services to determine what are the most common practices and where should we step first. We have gathered 47 responses from different countries. We disseminated it across Hungary with the help of the scientific chamber of the pharmacists, and also I had the pleasure to go to an international conference where also it did available for the attendees, and also we managed to disseminate it via personal emails for several deans across Europe. Overall, I had 4 ongoing projects and additional activities that I recently got admitted to the Harvard Medical School for a scholarship program. I would like to deep dive in the clinical investigation further. There are 2 ongoing investigations which also regarding the acute pancreatitis with aggressive and non-aggressive fluid resuscitation with lactated ringers, and I would like to further investigate ulinastatin in septic rat models, and I attended several Hungarian and international conferences along the way. Thank you for your attention.
So just a short question. You mentioned that ulinastatin is authorized only in Eastern countries, I guess China, and not in Western countries.
Yes.
Was the reason? Was it asked for authorization and was it rejected, or nothing happened in Europe?
Nothing happened, really. We can import it. So if we design randomized controlled trials, there is possibility to import it from Japan. It has got 3 weeks for transportation, so it could be a possible candidate for a randomized controlled trial in the future.
And did you, I'm sorry, one more question, did you see something about the adverse effect profile of this substance?
The published articles not mentioned really what was the adverse effects, so basically it's regarded safe. For now, it investigated also in the treatment of COVID-19, and they did not also discuss any adverse effects in these publications.
Thank you.
Thank you for the beautiful presentation. I just have a simple question. Do you know how much would it be to import to Hungary ulinastatin?
It would be around 100,000 forints for 10 or 5 ampoules of ulinastatin.
And how much would it be? It's for one therapy of a patient, or would it be enough for a few more?
Basically, the mentioned randomized control trials haven't got any common in the practice. How should we use it? Some recommend once a day, one recommends twice a day, so it needs further investigations to determine what will be the cost or the cost effectiveness of this therapy.
Thank you so much.
You mentioned some very interesting, generally known fact about PPIs. One of the most overused group. What do you think, what is the reason, what is the origin of this general overusage?
I think when the patients get admitted to the hospitals or discuss with their general practitioner some gastrointestinal related problems, the general practitioners tend to prescribe it and they fail to stop it. In the indication group of the PPIs, there are several restrictions, and they are mostly used for short therapies, 1 to 2 months at max. And there are some indications that needs, of course, a further use of this, but it's really, really low, this indication group. And in the hospitals, in my daily practice, I see that, so that it gets prescribed because of gastrointestinal protection, and this indication is also an off-label use. There are some theoretical parts that can be evidence for this or can be achieve this. However, there is no hard evidence. It can help the patients in the further in the future.
So what I not seen in your presentation, the forest plot, so I could not see the differences between the studies, but you say something about the heterogeneity. So how you can assess it?
Regarding the first part of your question, my SMS advised it to summarize in a table to have the time. About the heterogeneity, we cannot do actively about it, but we can discuss it in the discussion part and the limitation part of the manuscript. For example, in the ulinastatin, we have high heterogeneity. We theorize that because acute pancreatitis can affect both healthy and diseased individuals, and it's a really, really heterogeneous group. Therefore, we can only write it down as a limitation or consideration for the reviewer or the audience.
What was the numbers, the way how you can assess this heterogeneity? So why? So you say it's a high heterogeneity, but why you are saying that?
Because 99% is a really high number.
What number is proving you?
So it is not bad if it's high or low, as far as I learned, but we should look into it. What was the underlying factors that caused heterogeneity in our data pool? We looked at the baseline characteristics of the samples, of the intervention and the control group. There was no statistical differences in this regard. However, the data were not continuous in the 4S plots, but rather segregated, and that caused high heterogeneity.
So one number you are talking about, that's the I-square.
Yeah.
Yes. What I'm missing, I don't really like it without the confidence interval, but that's my opinion. The other thing, there is another, if you are making a random effects model, there is another number, other parameter that's telling you something about this.
Chi-squared.
That will be tau square.
Yes, tau squared, yes.
And another interesting thing, and maybe misleading in my opinion, but maybe not, so you show your outcome result as OR/MD. So, and I, of course, I see the confidence interval. So how you can, based on this, how you can say that which result is significant and which result is not?
We show the clinical, the confidence interval, and if it's not reaching 1, then it's statistically significant result.
Yes, so it's not including the 1. In that case, it's not. So it's significant, but for which? For the odds ratio or
for the odds ratios? Yes.
And for the mean differences?
Mean differences, it's the 0.
It's the 0.
What we're looking for.
Yes. So that's why it's it's for me it's a little bit strange to put them in the same table in this way. Thank you.